கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
Good evening, everybody, and we welcome you. I'm happy to welcome you all for this monthly meeting of this IFS South Tamil Nadu chapter. And it's been 2 months since we had this monthly meeting. In November, we had it. That was by Dr. Mona Pandurangi from Chennai. She spoke to us on pelvic ultrasound in infertility and optimizing the interpretation of those findings and by ultrasound. So after that, in December, because we had the IFS National Conference, we didn't have one. And again in January, because it was Foxy ASOG, we didn't have one. So again, we are back to form in February to do our monthly CMEs. So here we have a speaker today. Dr. Ramani will be is our patron, and she'll be welcoming the speaker. Yes, over to Ramani, please.
Sagitya, please share Ritu's CV.
Yes, ma'am.
Good evening, one and all. See, I welcome wholeheartedly for this webinar conducted on behalf of ISF Tamil Nadu. Today, we have a very learned speaker from Mumbai, that is Dr. Rita Hinduja, who is a senior consultant in Nova IVF. She is a member of Managing Committee of ISAR, Managing Committee of Maharashtra Chapter of ISAR, and editorial board team of Indian Expert Edition on Green Journal of OBG, Obstetrics and ACOG Official Journal, and editorial board of Indian Expert and Edition Eshrei Human Reproduction Journal. And she has received formal training in reproductive medicine from Barcelona, Spain, Tel Aviv. And then she is in the editorial board of Indian Expert Edition Green Journal and Human Reproduction. She has completed her master's in reproductive medicine from Homerton University, London, and diploma in reproductive medicine from Kiel University, Germany, certificate holder in genetic counseling from Martin Luther University, India. She is expertise in all techniques of ART, keen interest on poor ovarian reserve, and she has been a winner of so many awards from MOX, that is Mumbai OBGYN Society, that is Shanta by Gulab Chand Traveling Fellowship, GS Saraya Traveling Fellowship, Banuben Anavati Traveling Fellowship Award, Dr. Pramila Bhatia Award for Best Research Work, and L. Palep Award for Best Research in Recurrent Pregnancy Loss, Shanti Yadav Award for Best Research in Infertility, that is a Foxy Award, and again Foxy Dr. Kumut Mushkar Award for Best Research in Infertility, Korean Award for the Best Research in 2019-20, and Vasanta Ben Traveling Fellowship in 2021, and Eva Fogg Young Gynecologist Award. I think you have, we have to create some new awards so that you can get it. And she is the recipient of Best Popper Award in MOX Annual Conference in 2017-18, FEM Conference 2017, Central Asia Regional Conference organized by Association of Medical Women in India in 2010, Best Poster Award in MOX Youth Council Lead. She is an MMC accredited speaker. She has authored many chapters and also to her credit many publications in index journals, and she is an editor of Nova Handbook on Infertility, Abnormalities in the Pelvis, and editor of Nova Textbook of Infertility. So congratulations, Dr. Ritu. Wish you all plenty of laurels in future also, and I'm very sure the knowledge you are going to disperse for us is going to be a huge one, and we look forward for your talk.
Thank you,
you
ma'am.
for accepting our invitation.
Ma'am, it's an honor, and it's an honor to be introduced by you. I mean, I didn't even think this day would be something that I would experience. Thank you so much. Thank you for inviting me for this program. So I'll go ahead with my talk now. I'll be talking about complications in ART and how do you manage them and how do you kind of prevent them and what precautions should you take. So
Yes.
complications that can occur in ART, that is assisted reproductive techniques. I'll talk mainly about IVF. The complications can occur in various stages where you are inducing ovulation, when you are retrieving the oocyte, when you are doing the embryo transfer. And I will also be talking about psychological complication and administrative complications, which are also very important when you are running an IVF unit. The role of reproductive medicine that we as clinicians have to kind of play when we are, practicing reproductive medicine is not only the treatment, but we have to make sure that we prevent these complications, and we have to establish a critical balance between efficacy and safety in ART. And with the specific law in place, we all know the basic spine by which we have to, kind of practice, but also there can be a lot of other complications aside from the ART law, which I'm not going to get into in this talk. So coming to complications of ovulation induction, in ovulation induction, 80% of women are likely to respond optimally, provided the right regimen of controlled ovarian stimulation is used with adequate monitoring. 10% are likely to over-respond with or without OHSS, and 10% may respond poorly or not respond at all. How do you decide the stimulation protocols? So it's very important in order to prevent a certain complication from occurring. You have to be very mindful from the very beginning as to how to choose your stimulation protocol. So you have to begin with a standardized protocol that has been used either in your unit or you have learned from your seniors. But you have to individualize that protocol. You have to also monitor whether there is a proper response and an improper response to that standard protocol. And you have to be able to identify special situations like poor responders and hyper responders. Identification of these special situations, timely identification, I would say, plays a very critical role into you managing the poor responders and trying to improve the outcome, and also in avoiding symptoms of OHSS. You have to consider in individualizing the stimulation protocol, the age of the patient, the response to the treatment in the past. It's very, very important that you elicit this history or you have gone through the file of the patient who has come to you to make sure that you know what previous protocols were used if she has already undergone an IVF or an IUI cycle in another center. And you have to take into consideration the ovarian reserve. Now, I'm not going to get into the details of how you measure the ovarian reserve because this talk any which ways is very lengthy. So this is another talk in itself. So the problems that you can face while going ahead and stimulating the ovary is you can face day 2 ovarian cyst, you can have excessive response, you can have poor response, you can have thin endometrium, you can have premature ovulation, failure to ovulate, or luteinized unruptured follicle. Now I'm going to kind of touch upon each one of them and tell you how to tackle these things if you come across these things while stimulating a patient. So if you see a baseline ovarian cyst, what do you mean by a baseline ovarian cyst? A baseline ovarian cyst is a cyst that you see in the ovary on the second day of your period, provided that if you've done an earlier scan and you've not seen this cyst. So this cyst is on the second or the third day of the menstrual cycle. It is there. You've not seen this cyst before, because if you've seen this cyst before and if it is persistent, then it could be something else. A baseline TVS scan is important to rule out any ovarian cyst or residual ovarian activity from the previous ovulation induction before starting any cycle. What do you do when you find a cyst? You ask for previous cycle stimulation, if any, and whether any kind of drug was administered or not administered. You rule out any ovarian pathological cyst, especially endometrioma, which may look like corpus luteum at many a times. And you also have to rule out something which is known as a dermoid cyst, but dermoid cyst will not, and endometrioma will not be an occurrence which will happen randomly or on a day 2 scan. This is a cyst that you will see persisting through your scans. So if a simple cyst is more than 2 centimeters, you don't give ovulation induction. If it is less than 2 centimeters, you can start after confirming that it is a non-functional cyst. And how do you do that? You do that by doing a basal serum estradiol levels and a progesterone levels. If the cyst is less than 1.5 centimeters, you may call the patient the next day and start stimulation. So you should know what kind of ovarian cyst can occur. This again is a classification that you will need to be well versed with. You can have simple cysts and what are their appearance on the ultrasound. So you can read up on this. I'm not going to dwell into the details of it again. There can be a hemorrhagic cyst, an endometrioma, a dermoid, a hydrosalpinx sometimes does look like a cyst, but can be a hydrosalpinx. So you have to make sure that it is, if it is retort shaped, and if you could see folds inside of it, and you can see the bead on string sign, then it is a hydrosalpinx. And if you can see any septate, and or it could be a peritoneal inclusion cyst. Peritoneal inclusion cyst will mostly come with a history of previous surgeries. So if you have that, then maybe this could be one of your differential diagnoses. Now comes the inadequate response. So there can be 2 issues. First and foremost, that you think about if you've had an inadequate response is if you had it in the previous cycle, then what do you do in the new cycle? Whether you use recombinant or you use urinary or you use FSH or use HMG. So why do we use a particular formulation over the other, and what is the rationale is something that you will have to, kind of understand. So how do you decide that? Suppose if there was a previous stimulation which was done with maybe the dose of 225 and it did not give you any, if there was a poor response, you could increase the dose or you could change the formulation. If a woman has been stimulated with HMG and, she has, if you can see polycystic ovaries on the ultrasound, you could try to, convert your stimulation into a recombinant FSH stimulation. It is said that HMG stimulation and FSH stimulation, there is no difference. But, in polycystic ovaries, in my practice, and also there are a lot of papers which support that if you give recombinant FSH, you will get better response. So those are certain things that we can consider doing if the previous response has been inadequate. If in this particular cycle, if you have started with a low dose and you are getting an inadequate response on your follow-up day 6, day 7 scans, then you may consider doing a step-up protocol where after the first ultrasound, if you're not very convinced with the response in the ovaries that has been, that is coming, then you can increase the dose by 75 IU at every scan that you do. So you do the first scan at maybe day 6, and you do the next scan at day 9, and then you can keep increasing it by 75 IU in every scan to kind of elicit the desired response that you would like. So this is a standard step-up protocol. Also, there is a difference between urinary gonadotropins and recombinant preparations, the polytropin alpha. So there is no batch-to-batch variability in a recombinant batch than in a urinary gonadotropin. So maybe if, you could shift to a recombinant batch if you're seeing that, your gonadotropins are not giving you, the same gonadotropin is giving you a good response earlier, but has stopped giving you response once the batch changed. So you could consider that there could be an issue with the batch. And you could kind of change the batch, because we understand that urinary gonadotropins are cost effective, and Indian subcontinent, the patients do benefit if we use cost-effective formulation of gonadotropins. So, but if you're seeing there's a drastic shift in patients who are even normal responders and you're not getting the response, the desired response that you were expecting, then maybe you could go back and, check whether the batch of the gonadotropins has changed. So first and foremost, we need to describe what a poor response is. Who is a poor responder? So of course, there are a lot of definitions of poor responders, and it is a very dynamic definition. It keeps changing, and there are a lot of Poseidon criteria, etc. So you can read up on that. There is definitely a lack of uniform definition, but during ovarian stimulation, if you're seeing low peak of estradiol concentration, less than 500 picograms per ml, and you think that she's not someone who you expected this kind of response for, you can say that she's not responding optimally. If there are fewer follicles during ovulation induction, which are less than 3, or if there's a higher requirement of gonadotropins during stimulation, or there's a previous poor response, then you could consider her as having someone who's not having a good response. What are the predictors of poor response? So before you start stimulating, a woman's age, of course, an advanced age is a predictor for poor response. The endocrine parameters like FSH, LH, and AMH, and antral follicle count, these are predictors for poor response. What are your treatment strategies? Inducing a multifollicular response in a patient who is a known poor responder remains a challenge for all of us, and that's why it is a topic which keeps getting revisited. ESHRE after ESHRE and ASRM after ASRM, and they keep revising the definition and their treatment strategies. It is always tempting to increase the dose. You keep saying that, okay, fine, if she's not responding with 225, I'll take it up to 300. If she's not responding with 300, I'll take it up to 450. However, administering more than 450 IU per day does not appear to add significantly to the ovarian response or to improve the reproductive outcomes of the woman that you are stimulating. So if you've reached 450 IU, then going from 450 to 600 is not going to make a difference in her ovarian response and even in her reproductive outcomes. Now coming to ovarian hyperstimulation syndrome. OHSS is an iatrogenic complication. It is when you're giving exogenous drugs to stimulate follicular growth and ovulation. It is represented by a broad spectrum of manifestations, the cardinal features being massive follicular luteinization and shift of fluid from intravascular compartment to extravascular compartment. So the etiology is gonadotropin stimulation, which leads to multifollicular development, which leads to massive luteinization due to the HCG trigger, where there's extensive perifollicular neovascularization, which leads to an escape of VGF into peritoneal cavity and bloodstream, which leads to disruption of functional integrity of the blood vessels, which leads to increased capillary permeability and leads to fluid lost into extravascular spaces. So we've already spoken about it. Again, OHSS is a talk in its own, but you have to understand that there will be hypovolemia, there will be hemoconcentration, and you can have ascites if it is severe OHSS, and there could be decreased renal perfusion and acute renal failure. So this is why this is the most dreaded complication of ovarian stimulation. We need to be mindful from the very beginning of starting the stimulation. We need to recognize the patients who can go into OHSS and make sure that we've counseled them from the beginning itself, and to have a treatment strategy into perspective before you start stimulating these women. So classification again can be classified into mild, moderate, severe, and critical. You have to understand you can have two types of OHSS. It can be an early onset OHSS or a late onset OHSS. Early onset OHSS happens within 3 to 9 days of ovarian response, and you will see multifollicular growth. You will see estradiol levels more than 4,000. You'll see fluid accumulating in the pouch of Douglas. All these signs will be indicative of early OHSS. And late OHSS is when you have done the egg retrieval. Unfortunately, you were not, able to suspect that, this woman is going into OHSS. You did the embryo transfer and she's pregnant now, and the appearance of HCG in the blood will be the primary culprit of the late OHSS. So the risk factors, like I said, you need to identify these patients before you even start stimulating. Is age less than 35 years of age, a polycystic appearance of ovaries, a high E2 level prior to HCG trigger, which is more than 4,000 picograms per ml, multiple follicles which are more than 25. I am more cautious if anything that goes beyond 20, I'm in my practice, I will term it as OHSS. If you see the necklace sign, if again, like I said, if you've done an embryo transfer, do not do an embryo transfer in this woman, because once she gets pregnant, there will be late onset OHSS. And refrain from giving HCG in your luteal support. So the management of OHSS is cycle cancellation, luteal phase antagonist. So once you've done the egg retrieval, you can give antagonists to this woman who you are suspecting that she's going into OHSS. You can give antagonists on a daily basis for the next 5 days. And trust me, this works beautifully. You will not have a woman go into severe OHSS. You should call her for monitoring of her abdominal girth, her weight, her input output should be monitored. You should give her IV fluids if you're suspecting that she's going into, or she's a candidate or who can go into ovarian hyperstimulation syndrome. But luteal phase antagonist is a miraculous discovery into helping us manage OHSS. Even when we did freeze all and remote cycle transfers, there were still women who would, at least reach moderate OHSS. But with luteal phase antagonists, since the time I've adopted this, I have never seen a woman go even up to the stage of moderate OHSS. We are able to manage them so beautifully, but you should not get overconfident with the luteal phase antagonist administration. You should always call her back. You should always have her at least come in for the next 3 to 4 days, monitor her abdominal girth, monitor her weight, monitor her input output, make sure she is well hydrated. Make sure she takes water orally through, those 3 to 4 days, because oral consumption of water is much more important than your IV fluids that you'll be giving. So these are certain things that you will have to be mindful. Like I said, GnRH agonist triggering for ovulation, along with vitrification of whatever embryos are being created, and then doing a remote cycle transfer. So it is like you're segmenting the IVF cycle, has been the savior in OHSS. So, we've had OHSS free clinics because beautiful segmentation of IVF cycles is available, as well as luteal phase antagonist is available. You can give dopamine agonists and you can do coasting. However, I'm not a very big fan of coasting, and I'll talk about it why. So in cycle cancellation, nobody does this. So this is just, to kind of make sure that everything that's mentioned in the text is here. What they do is they continue the antagonist and they stop gonadotropins, and the antagonist kind of makes sure that she settles down and no rupture takes place. So, and then there's luteolysis, but nobody does cycle cancellation. Everyone retrieves the eggs, creates the embryos, give luteal phase antagonists, vitrifies them, and then does remote cycle transfer. Coasting, again, what is coasting? In coasting, gonadotropin stimulation is discontinued, antagonist is continued, and HCG is administered. Administration is deferred when patients are at a high risk, and then they're triggered when estradiol levels fall to a safer zone. But any interval longer than 24 hours from the last HMG to HCG will decrease the fertility rates, and they will decrease the oocyte quality, fertilization rates, and pregnancy rates when estradiol kind of falls drastically. That is why nobody now in their clinical practice actually follows coasting. Like I said, segmentation of the IVF cycle is the best kind of protocol that everyone does. So, like I said, freeze-all policy, you trigger with an agonist, oocytes are retrieved, all embryos are cryopreserved. This reduces the risk of OHSS to less than 1%. GnRH agonist for final oocyte maturation and GnRH antagonist cycles is the magic that we needed to prevent OHSS. So you need to identify these patients with high risk of developing an OHSS. You should do mild stimulation if you know that she's a woman with, with polycystic morphology. You should trigger with an agonist, vitrify your embryos. You can give dopamine agonist, antagonist in the luteal phase in case you have a doubt after egg retrieval. Management of OHSS, again, I will just touch the topic, the headings, because, again, a talk in its own. You can use colloids. You use cabergoline, that is a dopamine agonist. And in severe OHSS, once upon a time, decades back, we, used to aspirate ascites, but it's no longer done because we don't come to that stage at all now. So take home points are segmentation of an IVF cycle. Then we come to thin endometrium. Now, endometrial thickness, if you see over here, this is a study which was published by Chen et al., where they measured the endometrial thickness and the clinical pregnancy rate in IVF. And if you see, the higher pregnancy rates were, when the endometrium was above 6 millimeters in thickness. So, and if it was around 6 millimeters or less than 6 millimeters, it was only in, 0.3% of the cycles, and the pregnancy rate was not that very good. Clinical pregnancy rate in oocyte donation, on the other hand, they saw that even if the endometrial thickness was less than 7 mm, it didn't really drastically affect the clinical pregnancy rate. So this was very interesting. I found this very interesting. So the vital question is that what is the lower limit of a thin endometrium? 7 mm, 8 mm, 6 mm. So in literature, an endometrial thickness of 7 mm at the time of embryo implantation is considered suboptimal in assisted reproductive techniques. However, pregnancies have also been reported at an endometrial thickness of 4 mm and 5 mm. These studies kind of have emphasized that it's not so much so the thickness of the endometrium as it is the morphology of the endometrium. So if your endometrium looks good, it is a good trilaminar, and if you can see good blood flow, then you can achieve pregnancies in endometrial thickness as low as 4 mm and 5 mm as well. I have mentioned 2 studies that I did read, which mentioned achieving a pregnancy with thin endometrium. So thin endometrium can result from various factors. It could be inflammatory, it could be iatrogenic, it could have poor vascularity, low levels of estradiol. Some women have an inherently thin endometrium without any iatrogenic causes, and it could be idiopathic. So if you use clomiphene citrate in a stimulation, then of course endometrial thickness is thin, and because it has an anti-estrogen effect. But there is no dose dependent, like if you use 100 of clomiphene citrate, it'll be thinner, and if you use 50 of clomiphene citrate, it'll be not that thin. It doesn't depend like that. So clomiphene citrate and endometrial thinning occurs in 15 to 50% of cases where clomiphene citrate is used. It suppresses the pin pore formation. So pin pore formation is very, very important for embryo implantation. If it is a thin endometrium, you have kind of diagnosed, you can see a thin endometrium. You need to stop all drugs given to the patient. Stop the drugs, let her get her periods, evaluate her in a natural cycle. See how her endometrium grows without any exogenous hormones or HRT being given. If there is a normal endometrium in a natural cycle, that means it rules out endometrial pathology. And you can do natural cycle FETs. So, if you're facing that the endometrium is not growing in an HRT cycle, the best way to do it is do a natural cycle FET. You monitor the woman up to, you feel that the dominant follicle has grown up to 18 mm. You trigger her when, the follicle is 18 mm. You consider that you've done an egg retrieval after 36 hours, and then you start progesterone. And then if you're doing a blast transfer, you count the days from the day that after 36 hours of the trigger, you count your 6 days and you transfer the blastocyst. You can check hormones like estradiol and prolactin levels. But what I do generally is stop all medication, check all her hormonal profile, and monitor her in a natural cycle. That is the best thing you can do before you move on to any other strategies. You can do a color Doppler to look for endometrial vascularity, and always do a 3D volume calculation in women who have thin endometrium. Hysteroscopy, if she's not creating a good endometrium in a natural cycle, then hysteroscopy is something which is warranted. So you should do it. You should rule out Asherman's and adhesions or fibrosis in the uterine cavity. Uh, Again, I am not a very big believer into increasing the estrogen dosage that is given. I would rather change the formulation of estrogen being given. So if she was in valorate, I will shift her to hemihydrate. Or if she's not responding to oral, then I would shift her to subcutaneous estrogen applications. But increasing it, I don't think it really makes any sense. So again, I think changing the formulation helps much better. There are a lot of adjuvants that can be given, like Ecosprin, GCSF, but Cochrane database always says that it doesn't support these adjuvants. But again, there are a lot of people who use adjuvants in their practices. So if you feel that these sildenafil, Ecosprin, GCSF are something that is helping you, you could consider that. There are adjuvants available, and there are studies on these adjuvants. Again, now I'll come to premature LH rise in an ovulation stimulation. So premature LH rise is defined as LH more than or equal to 10 milli international units per ml, and premature progesterone rise as progesterone more than 2 nanograms per ml before ovulation. If using HMG, which has LH-like activity obtained from HCG content of or has been previously suggested as a cause of elevated progesterone levels. But high FSH dosage employed during stimulation causes increased ovarian steroidogenic activity, can also lead to premature LH rise. How do you overcome this? You use appropriate stimulation. You don't use such high doses of gonadotropins, and you use an antagonist as soon as your lead follicle is 14 mm. Again, there are two protocols, the flexible protocol or the fixed protocol. In the flexible protocol, you add antagonists when the lead follicle is 14 millimeters in diameter. Fixed protocol is when you add antagonist when on day 7, irrespective of what the size of the follicles is. Failure of the follicle to rupture. How do? You need to first confirm whether the follicle has ruptured or not ruptured. You confirm it because it may, you will see a corpus luteum. You check for progesterogenic activity in the endometrium. It will start whitening out. The triple layer will start getting blurred out, and you check for serum progesterone levels. Whether the unruptured is recurrent, you have to check for it in, if it's happening cycle after cycle. But very often it is a random event which does not require any treatment. However, unruptured follicles are common in polycystic ovarian syndrome, endometriosis, and permethrin citrate cycles. What you could think about is the HCG, right? But if you've already given HCG, then and it's still not rupturing, then you need to know whether it was administered properly or not administered properly. What was the brand? Is that one brand which is giving you an issue over and over again, and whether the cold chain was maintained or not maintained. Also the dose, sometimes a suboptimal dose of HCG is given, and that could lead to the follicle not rupturing. And if there has been a time delay of taking the HCG trigger. So these are certain things that you need to evaluate. Giving a repeat dose really doesn't have any kind of value. So it doesn't make any sense. But if you want to give it in your practice, you could, but it doesn't make any sense. GnRH analog is a substitute to HCG. So if it is not rupturing with HCG, you could consider giving an agonist trigger and seeing if the follicles rupture. Luteinized unruptured follicle syndrome is defined as a failure of ovulation in which, despite the absence of follicular rupture and release of oocyte, the unruptured follicle undergoes luteinization under the action of LH. LUF is seen in 10% of menstrual cycle of normal fertile women. A higher incidence is reported in infertile women and can happen spontaneously or in stimulated cycles. So the reasons for LUF can be poor oocyte quality or decreased ovarian reserve, endometriosis, unexplained infertility, pelvic adhesions, use of NSAIDs. This is very important, and somehow we, forget to ask this in history. So if your patient has a history of migraine or arthritis, and if for that they're taking regular painkillers, which are NSAIDs, then, please tell them not to take their painkiller on the day that you're giving the HCG or you're giving the trigger shot, because that prevents rupture and that will lead to a luteinized unruptured follicle. So the use of NSAIDs is something that does lead to luteinized unruptured follicle. Again, I've already spoken about the preparation of the injection and, injection problem, and the dose should be right. We've already touched all of these, so I'm not going to go into it. To conclude, ovulation induction is an art. Protocols should be individualized according to patients and circumstances. Now, coming to complications of oocyte retrievals, we can have a dilemma in anesthesia, delayed oocyte retrieval. Sometimes the patient takes the HCG at the wrong time or doesn't reach the center in time. Bleeding following oocyte retrievals, inaccessible ovaries, endometriotic cyst at oocyte retrieval, and empty follicle syndrome. So I'm going to be touching on all of these. Oocyte retrieval is a painful process, and it's therefore necessary to use methods of anesthesia, and which will have analgesia because there will be pain after the egg retrieval. And you need to have minimum adverse effects and should not have any effect on the embryo or the pregnancy outcome. And there are numerous published studies promoting a wide variety of techniques. They include general anesthesia, which nobody gives in our practices, paracervical block. Now, with paracervical block, it is an effective method, but what can happen is that there's a close proximity of the uterine artery and vein, means there is a risk of direct intravascular injection, and it can lead to toxic systemic effects. So paracervical block is reserved for people who cannot take sedation. So, you can reserve those for patients who cannot take propofol, etc. Regional anesthesia, that is the spinal or the epidural. Again, it is not something that, we generally do our egg retrievals in, because it's a short duration of process, and there is post-procedural drowsiness, and in women who take spinal and epidural. And also, it is a more invasive process, and it's best avoided. What we do use mostly is propofol. We do use sedation, and it is the best method of anesthesia for oocyte retrieval. So we do use some kind of analgesia as well as propofol. So this is the best combination for egg retrieval. What happens when we go in for delayed oocyte retrieval? So I'm going to present a case where a patient has presented for oocyte retrieval late, which is 60 hours instead of 36 hours after the HCG injection. It is probable that all the follicles have ruptured and the oocytes have been released into the peritoneal cavity. What do you do next? So you cancel the oocyte retrieval and the cycle. This is the most prudent course of action, as going ahead with the oocyte retrieval will expose the patient to the cost and the potential risk of anesthesia and surgical procedure with little hope of benefit. The chances of retrieving oocytes this late after HCG injection will be very low. And even if they were retrieved, they are likely to be post-mature with a low chances of achieving a pregnancy. So there have been case reports of collecting oocytes from follicles 60 hours after the HCG injection, or from the fluid in the pouch of Douglas after spontaneous ovulation, but these are exceptions. And the chances of retrieving the oocytes, let alone achieving a pregnancy, is very low. It must be done with patients' full understanding of uncertainty and the outcome of low probability of success. But before you take up this patient for egg retrieval or the procedure, you should always do an ultrasound to see whether you can actually see the follicles or not see the follicles. And also, if you can see fluid in the pouch of Douglas, the patient should be informed that all your follicles have ruptured. I'm going to try and, aspirate the fluid which is collected in the pouch of Douglas and see if I can get any oocytes. But the most prudent step, like I said, would be canceling the cycle and then stimulating her in the next cycle. So how do you prevent this from happening? See, considering the different drugs and the, various scheduling which is involved in an IVF process, it's not unusual for few patients to get some of them wrong. Perhaps the most critical of all drugs and timings to outcome of treatment is the HCG injection. The window of opportunity is low, only to a few hours, and there are no second chances in this particular case. So therefore, IVF programs should endeavor to explain clearly to patients the importance of HCG timing, give them verbal and written instructions, and perhaps follow that up with a telephone or a text message reminder. What do you do when there is a bleeding following oocyte retrieval? Vaginal bleeding is the most common complication of transvaginal oocyte retrieval, occurring in 1 to 3% of cases. Intra-abdominal bleeding occurs in less than 1 in 1,000 transvaginal oocyte retrievals. However, it can be life-threatening. Severe intra-abdominal bleeding is rare. However, it can be life-threatening. It can be caused by direct injury to ovarian parametrial or pelvic vessels or by trauma to pelvic organs. Serious cases of injury to iliac vessels have been described as a result of misidentification of iliac vessels as ovarian follicles. The management option, vaginal bleeding is treatable in majority of the cases by the application of local pressure or suturing of bleeding point. Severe abdominal pain, even in the absence of intra-abdominal fluid, has to be taken seriously, and the possibility of bleeding should be considered. On the basis of clinical presentation, laparoscopy or laparotomy may be necessary to identify and secure the source of bleeding. In case of grossly enlarged ovaries, the open method is recommended, and an extendable incision for a laparotomy should be done. The hyperstimulated ovaries may look abnormal to an inexperienced eye, and therefore there should be a liaison between the ART specialist and the operating team. During oocyte retrieval, the clinician should avoid repeated punctures and movements of the needle in the vaginal wall, because this can cause tearing of the ovary and bleeding. The aim should be to perform the procedure with as few punctures of the vagina as possible. It is also important to avoid repeated penetration of the ovary and follicles in order to reduce the possibility of intraperitoneal bleeding. Over distension of the aspirated follicle during follicular flushing must be avoided in order to reduce the risk of follicular rupture. Serious injuries to the iliac vessel due to their misidentification as ovarian follicles can be avoided if the clinician carefully visualizes all round structures in the longitudinal and the transfer accesses to distinguish vessels from follicles. What do you do when you have a patient with inaccessible ovaries during oocyte retrieval? In about 1.7% of cases, one or both ovaries may be inaccessible at transvaginal oocyte retrieval. This is usually because of pelvic surgery, which is done in the past, uterine fibroids, adhesions, or endometriosis. Moreover, congenital abnormalities of the female tract may render transvaginal access of oocyte retrieval almost impossible. How do you go about doing it? You empty the bladder before doing the egg retrieval. That is a very, very essential step, because when it is full, it rises into the uterus and the ovary rise into the abdomen and could lift the pelvic organs, including the ovaries with it. Therefore, the patient should be asked to completely empty the bladder before transvaginal oocyte retrieval, even if they do not feel the urge to urinate. Intraoperatively, if one or both the ovaries are found to be inaccessible and the bladder is full, a disposable catheter should be used to empty the bladder, as this can bring the ovaries closer to the vagina and render them accessible. Manipulation and positioning by abdominal pressure can be done. Vaginal scan probe manipulation, that is tugging the probe to the appropriate vaginal fornix with the use of appropriate pressure, with or without concomitant abdominal pressure, can bring an inaccessible ovary closer to the vaginal wall. Sometimes reverse Tenderberg's position and lateral table tilt can also help. You can use a tenaculum on the patient's cervix with downward traction. However, we don't use it in our practices because, where will you put the ultrasound probe and the tenaculum together? It is a serious issue. But this has been reported to be helpful in oocyte retrievals where the ovary was found behind the uterus, and this maneuver can bring an ovary closer to the vaginal probe. So there has been transvaginal, transmyometral oocyte retrieval, which can be done, but it should be done with someone who has the expertise of doing it, who has done it in the past. So if you're someone who has just started doing oocyte retrievals, please do not attempt this unless you are under supervision from someone who is senior. So you can go through the vaginal probe, through the myometrium of the uterus, and then access the ovary, which is, kind of stuck behind the uterus. A trans-abdominal ultrasound guided retrieval, again, should be done by someone who has done it before, who has the experience. I have seen it done. I've never done it myself. So if I have to do it, I would also call a senior who's done it before. And of course, a laparoscopic oocyte retrieval can be done. Now, if you accidentally aspirated an endometriotic cyst during oocyte retrieval, management option is to postpone the treatment and to perform cystectomy if the cyst is coming in. If you've seen the ovarian, if you've seen the transvaginal scan and you think that you will not be able to do the oocyte retrieval without avoiding the endometrioma, then you should not go ahead with the stimulation. You should first make sure that you operate on this woman, make sure the endometrioma is removed, and then stimulate the woman, and then go ahead with egg retrieval. So it's very important that you identify the right women with endometriomas if you want to go ahead with stimulation with endometriomas and do the egg retrieval. You should know that you should be able to aspirate the follicles. If you think if you think that you will not be able to access the follicles and it's going to come in your way, it's better to first do the surgery and then do the stimulation and the oocyte retrieval. Or if you are stimulating while the endometrioma is still there, you need to aspirate the follicles which are easily accessible. Please do not rupture, do not go through the endometrioma, do not rupture the endometrioma. And if you do, by mistake, do puncture it, then you have to give her antibiotics, and you have to make sure that, there is no tract formation, there is no infection. So I'll come to that later. Where did I put this? Yeah, so you need to give concomitant antibiotics and reduce the risk of infection. Then we come to empty follicle syndrome. That can happen. If you have empty follicle syndrome, you need to understand that one is a genuine empty follicle syndrome and one is false empty follicle syndrome. So now in genuine empty follicle syndrome, which is very, very rare, there is failure to retrieve oocytes from mature follicles with optimal HCG levels on the day of oocyte retrieval, or optimal LH levels 12 hours post the trigger. This cycle cannot be rescued with a repeat trigger. However, in false empty follicle syndrome, which is most common, there's failure to retrieve oocytes with low HCG levels due to error in the administration or the decreased bioavailability of the HCG or inappropriately administered agonist or HCG trigger. The cycle can be rescued with a repeat trigger. It is a sporadic event and the incidence is 0.0045%. There are two types. I've already spoken to you about it. The borderline form of empty follicular syndrome, where very few mature and immature oocytes are recovered from several mature follicles. This may be explained by a defect in the process that results in oocyte maturation and cumulus cell expansion. So you've got eggs, but you've not got as many as you were expecting. Genuine empty follicle syndrome, there is a dysfunctional follicular genesis. The granulosa cells have increased pro-apoptotic gene and decreased transcripts. Oocytes lost in late follicular genesis due to apoptosis. You can also see this in ovarian aging. The pathophysiology of genuine empty follicular syndrome is faulty oocyte development and maturation, and also dysfunctional signaling between cumulus cells and oocyte, or receptor polymorphism, or pericentric inversion or infragile site of chromosome 2. Hence, empty follicular syndrome is linked with ovarian aging or poor ovarian reserve, or both. So the recurrence of genuine empty follicular syndrome is very high. Counseling is of profound importance, especially in advanced age group. The risk factors are previous history of empty follicular syndrome in an IVF somewhere else, advanced maternal age, diminished ovarian reserve, longer duration of infertility, ovarian resistance to various stimulation drugs, obesity, higher baseline FSH levels, and lower estradiol levels on the day of trigger. What do? You confirm the action of trigger first and foremost. You take the HCG in urine or follicular fluid. You can either use the urine pregnancy test, and you can take the follicular fluid and put it on the urine pregnancy test and then see whether the HCG trigger has acted or not. Now, this can only be done when you have given an HCG trigger. It cannot be done if you've given an agonist trigger alone, right? And if, even if it doesn't come in the urine pregnancy test strip, you could send your blood levels, you could draw blood levels, and, but the report will come the next day. So the fastest way to do it is take the follicular fluid in your laboratory, take the UPD strip, and then check for whether there has been an action of HCG or not. You can do a 12-hour post-trigger LH of 15 milli-international units per liter, or a 12-hour post-trigger progesterone, which is more than 3.5 nanogram per ml. Now, prevention and management of false empty follicular syndrome. The final triggering stimulation should be there. So you have to kind of make sure that there is no errors in the administration of the trigger. There's no error in the timing of the injection taken. There is no improper timing of oocyte retrieval. The batch, if you know this particular batch is not working, then maybe do not use that batch of trigger. Low bioavailability due to variation in absorption and clearance, and ovarian low bioavailability of the HCG. This is basically termed as the pharmaceutical industry syndrome more than in empty follicle syndrome. What can you do? You re-administer the HCG and re-aspirate in cases of false empty follicular syndrome. There is a flow chart. Yeah, okay. So the management of empty follicular syndrome, you aspirate one ovary, you get no oocyte, you check for serum HCG or follicular HCG. If the serum HCG is less than 40, again in our laboratories, what you could do is you could cancel the let the patient come out of anesthesia of POT. You cannot take the decision there and there itself, but what you could do is take the urine pregnancy test in the laboratory and check for the follicular HCG. If there is that means if the serum HCG is less than 40 milli international units per liter, then it is a false empty follicular syndrome. Then what you do is give a rescue trigger with HCG from a different batch, higher dose, or if you use urinary, you give recombinant HCG. And you repeat the retrieval 24 to 36 hours later. If the serum HCG is normal or more than 40 milli international units per liter, or pregnancy card test with follicular fluid is positive, then it is a genuine empty follicular syndrome. You try to aspirate the second ovary. If you still don't get any oocytes, then repeat the cycle with gentle stimulation and trigger with recombinant HCG or recombinant LH. You use GnRH agonist trigger in subsequent stimulation cycle with an antagonist protocol. This can also be done, or you could give dual trigger, or you could use the same protocol with different batch of HCG for triggering. So I've already spoken about this. Now we come to complications of embryo transfer. Embryo transfer is the final and most critical event in the success of an ART cycle. The goal of a successful ET is to deliver embryos atraumatically into the endometrial cavity where implantation is maximized. Poor technique accounts to up to 30% of all IVF failures. In a difficult transfer, additional instrumentation may be required, like holding the cervix with a tenaculum or the use of cervical dilatation. Again, not done in general practice. Poor ultrasound visualization of uterus can be a cause of difficult transfer. And what you could use is use an inner catheter and then thread the out. You could use the outer catheter and then thread the inner catheter in a difficult embryo transfer. If you touch the fundus of the uterus during ET, again, not a good sign. Again, you could have retained embryos. You could have coiling of the inner catheter inside the uterine cavity. And you could have resistance of the embryos while expelling when the piston of the syringe is being pushed. Or you could have presence of blood on the catheter tip. Now, if you have excessive mucus, while doing an embryo transfer, you remove the cervical mucus because this is an essential step, because this will plug your catheter and you will not be able to expel the embryos. The mucus can block the lumen. I've already spoken about it. So clean the cervical mucus with a sterile gauze or cotton dipped in media. If there's persistent mucus, what you could do is gently take your ET catheter and aspirate gently and then flush with culture media. If there is a presence of isthmocele can render the ET procedure technically more difficult. Difficult ET is seen in 20% of women. It increases the chances of depositing the embryo in the isthmocele. So you should do it very, very carefully. It should be done under the ultrasound guidance, ensuring that the catheter has bypassed the isthmocele and reached the place above the isthmocele, and you're depositing the embryos there. And the presence of the isthmocele can reduce pregnancy rates, and there are umpteen number of papers on this. If there has been a previous cesarean section, visualization of the cervix might be difficult as it is drawn up. The uterus can be adherent to the abdominal wall. The isthmocele formation with more cervical mucus and fluid in the endometrial cavity can be seen. There could be a long cervix. So in these cases, an afterload technique is preferred than a preload technique, or you could use a stilette if you're using a Wallace kind of a catheter. You can't have difficult cannulation of the cervix. The suspects when you're having difficult cannulation is acute anteversion or retroversion, cervical stenosis, or S-shaped cervical canal. The solution is to adequately fill the bladder You can use a firm catheter in place of a soft catheter. You could straighten the cervical canal by using a tenaculum and holding it with a tenaculum. You could use, again, it's mentioned in the textbook, so I'm mentioning it here. You could use a paracervical block, but you could do a transvaginal ET under anesthesia. What I don't do sounding of the uterus and dilatation of the cervix on the day of the embryo transfer. What I like to do is to do a mock transfer. I will talk about it. So I don't know where the slide is. So I generally like to do a mock transfer before I go in with the cycle, and I am planning embryo transfer so that you know what you're going to encounter. So that is how you prevent any kind of last minute troubles while doing an embryo transfer, and you will not have to cancel the embryo transfer and freeze the embryos, etc. So if you had a previous ectopic pregnancy in a patient, that means you should not deposit the embryos close to the fundus. You should not use a very forceful injection, you should not press the piston with a lot of force, and you should not use high volume fluid. What you could do, like I've already said, but you could also do a single blastocyst transfer or a day 5 transfer, and you could use slower injection speed, lower deposition of the embryos, and optimal fluid volume. You can have retained embryos. We've all had it in our practice. If the transfer catheter, if all of the embryos are retained, then what you could do is that you can immediately retransfer the embryos. What you have to make sure is that it is an atraumatic embryo transfer, whether it is a retransfer, the first transfer. You need to slowly withdraw the catheter. You should not withdraw the catheter with a lot of speed, because that will kind of pull the embryos along with it. And when you are withdrawing the catheter, you should make sure that there is pressure which is kept on the piston while the embryo transfer catheter is being withdrawn, so that there is no pressure changes and the embryo is not sucked out of the uterine cavity. Poor transfer outcomes can be when there is damage to the endometrium by the catheter, when you touch the fundus and the uterus has gone into uterine contraction, when there has been an abnormal site of embryo deposition, because sometimes what happens is that the embryo gets pulled down and it gets deposited in the lower part of the uterus than the upper part of the uterus. So instead of a mid cavity transfer, it can be a low cavity transfer, or the damage of the embryos within the catheter itself. So, like I said, it is always better to do your uterine cavity evaluation before posting a patient for endometrial to embryo transfer. The modalities with which you can evaluate the uterine cavity is an HSG, SSG, a 3D, or a hysteroscopy. Again, a mock transfer is the best thing to do. Even if you've done all of this, it's always best to have done a mock transfer for the patient before you post the patient for the real transfer. What is the angulation, you've done the transfer in this patient before, and you will have higher pregnancy rates if you've done a previous transfer, a previous trial transfer, and these are documented papers. So always do a mock transfer. When do you perform a mock transfer? It can be performed before starting your controlled ovarian hyperstimulation, at the time of oocyte retrieval, at the time of the actual transfer, but care must be taken not to go beyond 5 mm of the internal os under USG guidance, and always use an afterload technique, because you've negotiated the cervical canal and then you thread in the inner catheter. So the cornerstone of a perfect embryo transfer is the ease of the transfer. It should be done under ultrasound guidance, a mock transfer which is done before, good endometrial preparation, minimal instrumentation, minimum manipulation, soft catheter, and most importantly, the expertise of the clinician. Psychological complication, we all know that it does have a lot of impact on the outcomes of the IVF cycle. So although there have not been systemic studies in infertile women examining the impact of, different type of psychotherapy treatments that decrease psychiatric symptoms and stress in general population, it is likely that these people will benefit from intervention, because these people do need help. As a couple, as a woman undergoing ovarian stimulation and taking so many medications, going through embryo transfer, it is very, very important that there is help available. And that is why I think it is imperative that every IVF clinic does have a counselor, because we do need to help these women. And it has been a proven thing that women with lower stress levels have a higher success rate in IVF than women with higher stress levels. So there can be administrative complications. We've always heard about mix-ups which have happened in Western countries. There are more cases that come up where they say they gave birth to wrong children. So the incidence of errors, unfortunately, are rare, but mistakes are inevitable. Because of heavy clinical workload and distractions, there can be human errors. How to avoid it? You should have a strict system in place. You should avoid situations that can lead to errors such as insufficient staffing and insufficient training. You should avoid the manipulation of more than one sample at once in your IVF lab in shared working spaces. The general rule is suggests that safe and efficient ART laboratory operations requires one embryologist for every 150 ART cycles per year. The procedure for identification should be in place. You should have manual double witnessing system or an electronic witnessing where there is a barcode matching, or an RI witness, that is RIFD identification system, which is in place in your laboratories. In the end, I would like to conclude that every complication in ART can be predicted, prevented, and presided over. Thank you so much.
Thank you. Thank you very much, Neetu, for that exhaustive, very interesting lecture.
Thank you, ma'am.
I think we have come across all these complications, whatever you have mentioned. See, in earlier, 20 years back when we started, we never had the proper use of this agonistic trigger, and we were dependent only on HCG. And we have had cases where the patient had, first of my case had a massive ascites, pericardial effusion, and pleural effusion. So when I was consulting a physician, he said the count is 25,000 in the patient is in severe sepsis. Then I said, no, it is only ovarian hyperstimulation, and there we have to go for an ascites fluid tapping, then pleural effusion tapping, pericardial, everything, and ultimately the patient conceived. So, but
ma'am, thankfully, when I started practicing, it was an era where we didn't see all this, but I've heard of things happening. Yes.
Yeah. Recent past, I think we have never had even a single OHS. But of course, we do come across some empty follicle syndrome that, as you have said already, that is inevitable, and maybe a proper trigger, proper timing. And in obese patients, we have to be very careful. And the timing of the pickup, and sometimes dual trigger, maybe generally in most of our patients, we give only dual trigger.
Yes,
and so the incidence is very low. And of course, like how you said, the repeat trigger can help in the retrieval of at least few oocytes that we have come across.
Yes.
Then what else, Chitra? And endometrial embryo transfer is the most, as you said, that is the final verdict. And it should be, always mock transfer is very much needed. And with the previous second patients coming with previous secondary infertility, we do come across niche cases. And sometimes I now started doing this niche correction with the hysteroscopy. And of course, you have to be very careful when you transfer that. And what else? And proper luteal support. So we have come across patients who have not taken the injection properly in the luteal support. That has led to the failure. So each step in ART, you have entirely covered the clinical aspect of it. I think we should have asked our own embryologist who is FDA certified to give the embryological causes for this problems, what we troubleshoot. I think she'll be an ideal person. Maybe next time we can have it. But anyway, it was a wonderful, wonderful talk right from the start till the end. And our fellow students would have gained a lot from your lecture. Thank you, Ritu. Thank you.
Thank you, ma'am. Thank you so much. Thank you.
If anything else you want to add up, what are the what we
face? No. That was in obese patients now to reach for OM pickup from below. Like transvaginal is also getting very difficult if they are very obese. Getting the ovaries to the fornix is also difficult. Have you any time done an abdominal pickup?
Ma'am, I haven't. Like that's why I gave a disclaimer in the talk only. I've never done an abdominal pickup. So, ma'am, generally when you give a head high position and you make sure that
Also,
the leg
Ovaries
is
comes
lower,
down
yes,
because
they
of
kind of
gravity.
drop down, yes. But yes, in obese patient, what you would notice is that your probe, you need to go more inside with your probe than in normal weight patients. So, a new person who's doing the egg retrieval might get scared of it, but, that's how much their distance from their external vulva to their fornices is. So you have to be, and when you've done repeated scans during stimulation, you would know, you would be able to gauge it. So sometimes, your entire needle guide goes inside and you have to like kind of, put your needle and then put the guide. So you have to be very careful with the whole thing.
that's what. That was one thing that I thought I should bring into notice for everyone. Anyway, thank you very much for this excellent lecture. I see one. Wait a minute. I don't know if there are questions there. No. Are there any questions? Then the audience can post their questions in the chat box so that we can clear your doubts with Dr. Ritu. Okay. Okay.
Thank you, Ritu.
Thank you, ma'am. Thank you so much.
Okay. Thank you, audience. Thank you, Dr. Ritu, for giving us such a wonderful lecture.
Thank
We'll
you,
meet
Dr.
you again.
Supriya. Thank you.
Audience, again, we'll meet you again next month with a better topic and a good